In the last few weeks, evolving science has challenged some of what we thought we knew about COVID-19. What are these developments and how should we respond to them? For the answer, stay tuned. Hi everyone, it's Dr. Timothy. There's been a lot of evolution in the understanding of COVID-19, how it affects the human body, and how it's not quite what we thought it was. So the vision that we had of COVID-19 was that it was going to be similar to other viral causes of pneumonia and what's known as ARDS, Acute Respiratory Distress Syndrome. Many people do not have lungs that become very stiff the way they do in ARDS. So that's a difference. They seem to not require ventilators when their oxygen saturation gets below a certain point, as is true in pretty much every other cause of pneumonia. But people with COVID-19 seem to tolerate low oxygen saturations that normally would not be tolerated in other diseases. Furthermore, we're starting to see a bunch of strokes and other vascular events happening often in people younger than 50 years old. Now, early on in this pandemic, we heard that the people at highest risk would be the elderly, and then a number of conditions like diabetes and heart disease and respiratory diseases were felt to be things that would predispose people to the infection and to specifically having worse outcomes if they did become infected. I remember early on talking to a medical school classmate who was working in a hospital in New Jersey, but fairly close to New York City. So in other words, close to the epicenter of the epidemic at that time. And one thing that he told me that was fascinating was that almost all the patients they were seeing in the ICU were obese. Recent evidence is now suggesting that, for example, lung disease does not appear to be a particularly strong predictor of doing poorly with COVID-19. Right now, it's appearing that asthma, for example, and COPD, two common respiratory diseases, are not causing big bumps in COVID-19 mortality. So that was unexpected. What we've come to realize is that the virus also attacks the endothelium. Now, the endothelium is the thin, single-celled lining of capillaries and other blood vessels. And what can happen is a chain of events involving the immune system, etc., that result in blood clotting. And this appears to be the mechanism for strokes and other things we're seeing. Now, I saw a report just the other day, and again, observational early on, but very interesting. And that was deaths seem to be greatly disproportionate in people who have what's known as metabolic syndrome. It used to be called Syndrome X. This is a constellation of factors marked by insulin resistance primarily, elevated triglycerides, a type of blood fat, low levels of HDL cholesterol, high blood pressure, and particularly type 2 diabetes. And what was suggested was that patients who have any of these factors that point to metabolic syndrome seem to be at something like 10 times the risk of death than people who don't have these things. So it's a huge difference that we really totally hadn't seen coming. And so I think part of what we're going to want to do for preventive medicine is really look at that. Look at people who are obese, look at people who have the things that often go hand in hand with obesity, like those factors for metabolic syndrome. And by the way, abdominal obesity is another one of the factors that's part of the constellation of metabolic syndrome. Okay, abdominal obesity meaning primarily fat between the organs, inside the belly, not on the surface of the belly, but deep in the abdomen, intra-abdominal fat, which we know is very problematic from a metabolic standpoint. When there is an abundance of fat cells in the body, it predisposes to inflammation. There are actually inflammatory chemicals that are released by fat cells that help spur some of the inflammation that's chronic in that condition, and they may exacerbate the inflammatory and the immune response of the body to COVID-19. So how do we get after metabolic syndrome? It turns out medicine, in terms of drugs and procedures, does not have a lot to offer. There is a drug called metformin, which seems to increase sensitivity to insulin, which is not approved for this use, but which is being used in an off-label way by physicians to treat some people to try to prevent the complications from metabolic syndrome. Whether or not that works is yet to be proved, but there are theoretical reasons why this might be true, and metformin does seem to be a drug that's fairly well tolerated. But really, what works for metabolic syndrome is holistic healing, lifestyle medicine, diet, exercise, lifestyle, all these factors. This is where the real opportunity to make a difference can be. Now, in someone who is morbidly obese, someone who has very bad risk factors for metabolic syndrome, this is not something that you can turn around immediately, but you can start to, within days or weeks, move things in a better direction. So I've come up with a half dozen things that we can do specifically to try to address metabolic syndrome in a holistic way that may just make a difference in those of us who are probably at the greatest risk from this virus. Now, when we're talking holism, of course, we're primarily talking about dietary and lifestyle factors. One of the most important things you can do in terms of diet is to reduce the amount of added sugar to your diet. Avoid also probably certain fruits like dried fruit that are very high in sugar. Avoid putting sugar in anything or eating anything that has sugar in it. That's not easy to do for some people, of course, but the more you can cut back, the better it is. Try to follow Ayurvedic advice. Have your biggest meal of the day in the middle of the day, around noon or 1 o'clock, not late in the evening. Try to, if anything, have a very light dinner. Now, if you are going to skip a meal in the day, don't skip breakfast. Skip dinner. And one of the advantages of skipping dinner, if you end up doing that, and again, we're talking primarily about people who are overweight here or who have a lot of kapha in their natures. One of the advantages of skipping dinner is that you wind up with a huge number of hours, assuming you're not snacking between meals. You have a huge number of hours between lunch and breakfast the next day. And this is then kind of a mini fast, what's known as intermittent fasting. Basically eating nothing generally between dinner and breakfast. It might be 13 hours, might be 15 hours, might be 16 hours. Some people try to compress their calories even into fewer hours in the day. But the one study we have on cancer suggests greater than 13 hours between finishing dinner and starting breakfast with nothing in between seems to make a difference in the recurrence of invasive breast cancer. So, intermittent fasting. Now, the other thing that I think there's some very interesting results, there's a Canadian kidney doctor named Jason Fung who wrote a book called The Complete Book of Fasting, and he wrote some other books, one called The Obesity Code, one called The Diabetes Code, which are provocative, very interesting books with kind of a challenging but scientifically very plausible mechanisms to explain why the standard care for obesity and diabetes often is not that successful, and how fasting, for example, every other day fasting, where you eat normally one day and then only have water the following day, or he actually encourages bone broth during the day to get some sustenance, but to not do anything to trigger raises in blood sugar and the insulin response, which again are crucial in this disease. And Dr. Fung is actually he reports amazing results with people with diabetes and people who have obesity, that they often don't respond very well to low-carb diets, which theoretically could also be very helpful. But he's found that his patients have a very tough time sticking with low-carb diets. They just find it too onerous, and they don't tend to stay on it. They don't get great clinical results. But what he has found is that, surprisingly, perhaps, fasting for a day at a time seems to be something they can do and they can tolerate. I have actually, for the last year, fasted one day a week, and my body has totally gotten used to it. It's a bit of a psychological challenge in some ways, because I like to eat and I like the taste of food, and I miss it when I'm not eating. But the fact is, I don't actually feel a lot of hunger. This is a consequence of ketosis. Your body, when there isn't a source of sugar, like carbohydrates in the diet, it tends to instead break down fat stores in the body, generating this type of fat known as ketone bodies, which make the body ketotic. And one of the effects of ketosis is that it suppresses appetite. So he's having very good luck with patients who are fasting one or more days a week, typically with normal eating days interspersed. So that's potentially, I think, a very helpful thing. Again, not scientifically studied to anything like the extent we'd like it to be, but we do know that it appears to be very safe, and particularly for people who are overweight. This is something for people who are frail, borderline underweight. It's potentially risky to be fasting. But otherwise, if you're not frail, if you're not too elderly, if you're not too thin, this seems to be something that people can learn to tolerate quite well, and judging from the clinical experience, is something that's realistic for people to do. Now, exercise, of course, is also a huge factor. It does not need to be strenuous exercise. In fact, if the person with metabolic syndrome or obesity or type 2 diabetes has not been exercising a lot, you don't want them to do something too strong. So I would favor low to moderate intensity exercise, meeting the person where they are and gradually trying to titrate up a little bit over time. But you don't want the heart rate going crazy. You don't, in my opinion, want it at the upper end of the aerobic range. I think you want it much more toward the lower end, or even shy of that, as long as the person can be comfortable. Now, the other thing I would highly suggest for exercise, and I've talked about this elsewhere, is this notion of only breathing through the nose, both for the inhalation and for the exhalation. There's an excellent book by Dr. John Douillard called Body-Minded Sport, where he goes into the science behind this and how to do it in a lot of detail. Great book, highly recommend that. Part of the reason, by the way, for not encouraging super vigorous workouts in this risk group is that type of exercise where you're huffing and puffing and often breathing through the mouth tends to be kind of stress-inducing, and that with super activation of the sympathetic nervous system. And while it can reduce mental stress, it's hard on the nervous system and could potentially even be pro-inflammatory. So that's part of the reason. Get after stress, reduce stress. It doesn't have to be a long yoga practice if it's yoga. A few minutes a day, but doing it every day, if at all possible, is the best way to start, because that's the best way to build habit patterns. And it's really changing chronic habit patterns that can really take people who are maybe stuck with where they are with type 2 diabetes or metabolic syndrome and put them in a better place. Now, it's hard to motivate people to do this. But one of the beauties of doing it the way I'm describing, which is to meet people where they are and build up only very slowly, but stressing the dailiness of the practices, the exercise and the yoga, etc. Even after several days of doing this, people will start to feel better. And even though it's counterintuitive, it's feeling better, not fear of a fatal disease that turns out to be the strongest motivator of all. Okay, that's all for now. I hope this is helpful. Good luck to you all. Namaste.